Thank you, sir, for all your patience. Now we are again live on for the delegacy. So you can proceed, sir. Thank you.
Yeah, Janki, you can start.
Okay, sir. Thank you, sir. Good afternoon. Today is for Neonatal Pathshala. My topic is on neonatal sepsis, and under the guidance of Dr. Jayesh sir and Dr. Shwetal ma'am, I am Janki Shah, second year resident from Baroda Medical College. I am presenting a case of baby of Fatima Sheikh, 44 hours of life, old female child, and delivered on 23rd of June at 11:30 p.m. at Padara CHC and was admitted at Jamnabai Hospital, Vadodara. On maternal history, Fatima Sheikh, 22-year-old female with second gravida, residing at Ekta Nagar, Vadodara, belonging from lower socio-economic status. On previous obstetric history, history of menarche at 13 years of age, no significant obstetric history, with LMP on 16th October 2023 and EDD on 23rd of June on 2024. No bad obstetric history present. On antenatal history, Fatima Sheikh, patient mother, had taken total 4 antenatal visits at Padra CHC with 2 antenatal scans at 5th month and 7th month of gestation, which were normal. In first trimester, there is no history of fever with rash, any urinary tract infection, or any radiation exposure. In second trimester, taken 2 doses of tetanus toxin with 1 month apart, and iron folic acid tablets started at 3rd month of gestation. In third trimester, there is no history of any urinary tract infection or any radiation exposure or foul smelling discharge from vagina or any hypertension or diabetes. And history of approximately 8 to 9 kg weight gain was present throughout the pregnancy. On natal and postnatal history, she had history of leaking per vaginum for 18 hours, along with history of fever for 2 days before delivery. And she was admitted on 22nd of June at Padra CHC with labor pain, and patient was delivered via normal vaginal delivery, which was with spontaneous labor with vertex presentation and clear liquor. On postnatal history, single, alive, 1.9 kg female child, which was cried immediately after birth and delivered at Padra CHC. No resuscitation was required. Child was presented to Jamnabai Hospital at 26th hour of life with following complaints. Complaint of poor feeding since 3 to 4 hours, complaint of fast breathing, and complaint of decreased activity. On general examination, I had examined the patient in proper daylight. Patient was lethargic with weak cry was present. On examining the vital signs, temperature was 36.8 degrees Celsius, which was normal. Heart rate was 140 per minute. Respiratory rate was 72 per minute with grunting present and minimal intercostal retractions present. Peripheries were warm and pulses were well palpable with capillary refill time less than 3 seconds. On anthropometric examination, birth weight was 1.9 kg and receiving weight was 1.86 kg with head circumference of 31 centimeter and length was 40.5 centimeter. From that, Pondral index was calculated, which was 2.8, suggestive of symmetrical IUGR. So from above, currently patient is 36 week or 2 days late preterm with small 4 date. There was no cyanosis or any icterus, pallor, bulging fontanelle, or no any other clinical signs were seen. On head-to-toe examination, anterior fontanelle was normal, head size and shape was normal. Anterior fontanelle was palpable, approximately 2.6 by 3 centimeter, and posterior fontanelle was palpable to tip of finger. No swelling over face or no any redness or any eye discharge was present. No ear anomaly was present. No cleft lip, cleft palate or any natal tooth was present. Umbilical cord was intact with no discharge or redness over the site. Labia majora was covered with labia minora. Labia minora was covered with labia majora, and anal orifice was also present. No any polydactyly or syndactyly was present, and back and spine was normal. On systemic examination, patient was examined for respiratory system, bilateral air entry clear, but Silverman Anderson score, which is SS score, is 4 by 10. So according to SS score, patient was currently kept on CPAP support. On cardiovascular system examination, S1S2 present, heart sounds present with no murmur. On per abdomen examination, abdomen was soft, non-tender. Liver, spleen was not palpable. On CNS examination, patient was lethargic. So the provisional diagnosis is single, late preterm, 36 weeks 2 days, small for dead baby of 1.9 kg, female child, delivered by normal vaginal delivery, cried immediately after birth, clear liquor with history of leaking per vaginal for 18 hours, and respiratory distress requiring CPAP support with probable early onset sepsis.
Okay. How do you define a late preterm?
Ma'am, late preterm is less than 37 weeker, but from 34 to 37 weeker, we can say as late preterm.
Okay. So
30,
34 to
36
36.6.
plus 6 weeker. Yes, ma'am. Yes.
Okay. So are there any risk factors for sepsis in this? You took the history of the maternal history. Did you find any risk factors for sepsis?
Yes, ma'am. There are maternal risk factors are present, like history of maternal fever 2 days before delivery and leaking per vaginal since 18 hours are the risk factors.
Okay. And the liquor was not foul smelling.
No, ma'am.
Fine. So how do you label it as probable sepsis?
Ma'am, probable sepsis on clinically diagnosed means septic screen. Besides septic screen, on seeing the baby clinically, which was lethargic, and along with risk factors, 2 risk factors was present, so we can diagnose it as probable sepsis. If we have septic screen positive along with the risk factor present, then we can say it as a case of clinically sepsis present.
Okay. Proceed. Yeah. Yeah, you can go ahead. Yeah.
Yes, ma'am. After provisional diagnosis, on laboratory investigation, receiving RBS was 88 milligram per deciliter, which was normal. Total leukocyte count was 4,000 per cubic mm. Platelet count was normal, which was 2.5 lakh. With CRP was higher side, which was positive 15 milligram per deciliter. On CSF examination, in CSF, cells were less than 5 cells per cubic mm with protein 32 and sugar was 98, which was normal, and with concurrent sugar was 110. With on maternal vaginal swab examination, which was suggestive of Streptococcus pneumoniae organism.
Okay. So the septic screen was, can you go back to the previous slide? Yeah. So the septic screen, according to you, is positive.
Yes, ma'am.
So what do you consider as do you have any other parameters in the septic screen other than this?
Yes, ma'am. We can have micro ESR, which is significant for sepsis if we have micro ESR value more than 15 mm in 1 hour. Or we can have ANC count, means absolute neutrophil count. If we have less than 1,800 count, then we can consider it as a positive. One can, ma'am, immature to mature total neutrophilic count we can done. If it is more than 0.2, then it can also considered as positive septic screen. Means one of the parameter of septic screen.
Okay, what is the criteria, or do you do lumbar puncture in all the babies whom you
Ma'am, lumbar puncture, in case of any blood culture is positive, then we should go for lumbar puncture to rule out the PyoME. And if in case blood culture is negative, but clinical signs are present like irritability present, excessive crying is present, in case of late onset sepsis, if we consider, then we should go for lumbar puncture.
So late onset sepsis, everybody should undergo a lumbar puncture if you are suspecting
Yes, ma'am.
sepsis. And
Yes,
for
ma'am.
early onset sepsis, if you are strongly suspecting based on the clinical
Yes.
feature, or if
Yes.
the culture is positive, then we do a lumbar puncture.
Lumbar puncture. Yes, ma'am.
Proceed.
On chest X-ray was showing reticulogranular pattern, which was suggestive of pneumonia. Next. Treatment. Baby is currently kept on CPAP support with FiO2 of 21% and PEEP of 5. With injection, ampicillin and gentamicin antibiotics were started, and currently baby is on Manfits with IV fluids. In conclusion, ma'am, strategies to prevent early onset neonatal sepsis. Preventive strategies are like this. This include treatment for all pregnant females with a positive culture for vaginal swab for Streptococcus pneumoniae. So we could have gone for aggressive antibiotic treatment of affected neonates, and further assessment of risk factor for streptococcal pneumonia, neonatal sepsis, and for early prevention of strategies such as vaccination can be done in case of pregnancy, aims to protect the infants from the neonatal sepsis.
So what are the common causes of respiratory distress in late preterms?
Respiratory distress in case of late preterms means, ma'am, there is in case of prematurity is there, then low birth weight is there, then in case of late preterm.
So this child was a late preterm, you said.
Yes, ma'am.
So late preterm, 36 weeker, do you expect that in this setting there can be still surfactant deficiency or relative surfactant deficiency can be there? Or was it only sepsis which has caused this?
Ma'am, in case of IUGR babies, there is less chances of surfactant deficiency due to cortisol production will be there in case of IUGR babies.
Okay.
So,
But then
sepsis.
still there is an intrauterine infection, or if the child has come up with an early onset sepsis at 36 weeks, is there likelihood of causing decreased production of surfactant or injury to the alveolar cells producing the surfactant because of infection?
Yes, ma'am, in case of infection, in case of sepsis, if it can be there, but
Okay.
there are less chances for that.
Okay, proceed.
So this presentation of all about neonatal sepsis.
Correct. So, is this a common organism to be found in early onset sepsis?
Some common organism in early onset sepsis are, yes, ma'am, like Klebsiella, then E. coli, Streptococcus pneumoniae are common organism which we can found in case of early onset sepsis.
Okay. What is the precautions we can take to avoid the respiratory distress in these late preterms? What are the precautions, or what are the antenatal as well as the postnatal factors which can be taken care of?
Yes, ma'am. So we have to prevent the risk factors. Like risk factor is present, like prematurity is there. In case of hypertension, diabetes, there will be prematurity be present. So early diagnosis and treatment can prevent prematurity. Then in case of labor, multiple pervaginal examination can cause this type of sepsis. Then prolonged duration of labor, like first and second stage prolonged duration can cause this type of sepsis. So we can prevent this. Then any foul smelling discharge after treating it with antibiotics in females who are pregnant. So we can treat also this. Then in case of perinatal asphyxia, by diagnosing early means by doing CTG, means cardiotopography, doing heart sound checking, we can prevent it also.
Right. And what are the non-specific features of sepsis which you should be looking for in a newborn, in a term or a preterm? What are the non-specific features? In this child also you had.
Non-specific.
What are the signs which you looked for and you found that they could be septic? What is that you saw?
Signs mean, ma'am, lethargic with dull activity will be seen. Then every system can be affected. Like on CNS examination, if we see, then seizures can be present, irritability, excessive crying if there. Then in case of like NEC, in case of necrotizing enterocolitis, there will be vomiting with abdominal distension will be present. Then respiratory distress, like in a form of respiratory distress, it can also present. Then it can also present like poor perfusion. Then shock will be developed also. Mottling will be seen. Pallor can be seen.
Can apnea be
Sign
present as a sign of sepsis?
Sorry, ma'am.
Can there be apnea? Apnea can be
Apnea,
there in a late preterm.
yes, ma'am. As a sign of sepsis, it can present in case of anemia. If a child is anemic, pallor is there, then in case of that, apnea will be also present. In case of any metabolic abnormality, like if child is hypoglycemic, if hypocalcemic, then apnea can also be present.
So will it be primary or secondary apnea in such a case?
Secondary apnea, ma'am.
So how do you label a primary apnea?
Primary apnea means ma'am, there is no underlying cause for it. In case of mostly apnea of prematurity, in case of preterm babies, if apnea is there, so after all the causes are ruled out, we can say it is a primary apnea.
Right. Okay. So what are the complications we encounter in late preterms? Why is late preterm being so given so much of importance now? Because more and more deliveries are occurring. Many deliveries are occurring now late as late preterm deliveries. So why do we give so much importance to late preterms? What are the complications likely in them?
Ma'am, complications like hypothermia can occur, hypoglycemia can occur, hypocalcemia, then hyponatremia can occur in case of a late preterm. If in case of sepsis is there, then respiratory distress can be there. In case of LSTS, there will be TTN can be there, transient tachypnea of newborn. Then due to prolonged labor, meconium aspiration can be there. Mostly in case of term and late term babies, it commonly occur, but it can occur. Then pneumothorax can be occur in case of late preterm babies. Then um, any heart disease may be there in case of patent ductus arteriosus. PDA can be there. Then
Fine. In this case, your blood culture was positive? You took the
no,
blood?
ma'am. Yes, ma'am. Blood culture was taken, but blood culture was showing no organism. No, blood culture was negative.
Okay. So how long did you give the antibiotics?
Ma'am, if we suspect, according to guidelines, if we suspect sepsis clinically and blood culture is negative, then we have to continue antibiotics for 3 to 5 days. But if blood culture is positive, in that case, we have to continue it for the 14 days. And in case of septic screen is positive along with blood culture negative, but clinically we suspecting sepsis, then we can continue it for 7 days. And if CSF is ruled out of if CSF suggestive of PyoME, then in case of meningitis we have to continue antibiotic for 21 days.
Right. How do you collect a blood culture?
And blood culture collected by aseptical precautions and proper first hand wash and then wearing gloves, aseptically properly by betadine and spirit. Firstly, we will clean the site for the blood culture, and by inserting a new VF or we will not collect blood culture from the previous VF or any previous site. We will collect from the new site, and at least 2 ml of blood culture should be taken. 2 to 5 ml.
So blood culture is the gold standard for diagnosis of sepsis, right?
Yes. Yes.
So you have to collect the blood culture with all due precautions, right?
Yes.
So you have to start. You have where you are going to prick. You have to start concentrically from there with isopropyl alcohol, and then you can use betadine if it's not a very preterm child. Okay, and then you wait for 1 minute, let it dry, and then put the prick and collect
Yes.
it. Right.
Yes.
Correct. Anybody else wants to ask questions? Like they can please go ahead and ask. So anything else anybody wants to point out?
Vanna, you only have to ask the question.
Yeah. So anybody else, Dr. Jayesh wants to point something in this case, particularly? Okay.
Actually,
So was the USG head warranted in this child?
Sorry, ma'am.
sorry, ma'am.
Is it an indication to do ultrasound head in this child?
Indication, ma'am, it is means if patient had irritability or excessive crying like features are present, then we can go for USG head screening. And in
But
case
your
of
CSF was normal, right?
yes,
Mm.
ma'am.
Correct. So if this child is beyond 34 weeks and you
Yes,
have done a CSF and it is normal, so unless and until this child required, you know, intervention like mechanical ventilation, prolonged ventilation, then even beyond for 34 weeks, we
yes,
may go ahead and do a ultrasound head, right?
yes, ma'am.
Okay. Will this child require an ROP screening?
This child, ma'am, if we give oxygen support for prolonged time of period, then we can go for ROP screening.
So how long was this child on CPAP?
Then, ma'am, 3 days.
Okay. And what was the FiO2 requirement?
FiO2 requirement, ma'am, 21%.
Was 21%, right?
Yes, ma'am.
Okay. So do you think you can fit this child into the criteria for what we do as for HMD CPAP cases? That when do you think of giving surfactant in such a child? If the child is put on CPAP, what will be the indication of giving surfactant in this child?
Ma'am, in case of if child on CPAP with FiO2 requirement of more than 40% if there, and still child is having a severe distress, then we can matlab give surfactant.
Okay, fine. So anything in follow-up you would like to see in such children? What will you look for in follow-up?
On follow-up, we will look for proper feeding pattern. Then any signs of irritability if present, we will explain all the danger signs to mother, like excessive crying or weak crying or dull activity or lethargic or vomiting or abdominal distension if there or fever if there. Uh,
See, late preterm,
Vaccination.
correct. Yeah. So late preterms are not always, they may have feeding issues also. So you have
Yes,
to ensure that the mother has learned properly the breastfeeding. So generally,
yes,
many a times it happens that if we discharge the late preterms early, then they come back to us for feeding issues. They come back to us for, they can have things like hyperbilirubinemia because of improper feeding patterns,
yes,
you know. So those things have to be looked for, especially in the late preterms.
yes.
And I think this case was very clear cut that there was a risk factor in the form of, so the risk factor for late preterm itself was preterm labor,
Yes, ma'am.
premature prolonged rupture of membranes was there to give as a focus for early onset sepsis, right?
Yes, ma'am.
And so what can be the other causes why for the late preterms? You already told me a few, like,
Yes.
so can some maternal causes wherein we are maternal causes lead to other than this premature onset of labor be the cause of preterm deliveries?
Other maternal causes like hypertension, then diabetes, then in case of chorioamnionitis, which is the terminology which includes like along with a fetal tachycardia will be present, then on maternal investigations, there will be total leukocyte counts will be raised with foul smelling discharge may be present from vagina.
Right. So what do you think should be if an obstetric colleague of yours asks what should be the ideal time to deliver a baby out if mother is okay, baby is okay, then what will you tell as an ideal weeks of gestation to deliver the baby out if it is a planned cesarean section? Can
Ma'am,
you do have any idea what you can tell as a relatively safe limit? So it should
37
be,
to 40 week,
yeah.
37 to 40 weeks.
So just now you told me that 37 to 40 weeks. So I would say it should be 38 weeks and beyond, right? So to label somebody as 37 weeks onwards till 38 or maybe 37.6, what do you label them as? early term.
Early term. Yes, ma'am. Early term.
Then as early term.
Yes,
Okay, fine. So because of many assisted reproductive techniques, twin pregnancies, and
yes,
more and more of fetal surveillance which is being done, okay, obstetric practices have improved, so they find that there is not fetal well-being is not maintained, or there is an altered Doppler, so more and more late preterms are being
yes,
delivered, right?
yes.
So what is another cause of respiratory distress which can be in late preterms who are delivered by cesarean section
It is
other than
TTM, TTM, transient tachypnea of newborn.
correct? So retained lung fluid is a um, important cause of respiratory distress, right? Okay. So as far as sepsis is concerned, I think you have done everything. You have done the culture, you have done CSF, and if this child would have had scleroderma, was there a role of any other thing which you could have added as a part of treatment of sepsis?
Um, uh, Second line and third line antibiotics can be added.
Okay. I'm not sure, but is still an exchange transfusion proposed as a first line treatment if this child comes to you directly at scleroderma, right? So 50% risk reduction in the mortality may be achieved if you do an immediate exchange transfusion, right? So that is
Yes.
what I am not very sure whether it is still being practiced like that, but this is what is practically what we have seen, and it has given very good results. Is there any role of IVIG in sepsis? There's no role. Correct. Okay, fine. I think she has answered enough. Anybody wants to comment anything else about the case, they can go ahead with that. Yeah.
I would like to share something.
Yeah.
Looking to the history retrospectively, baby was delivered a late preterm. Mother was already having 2 days of fever, and there was 18 hours of leaking per vaginum. So at 26 hour of life, child develop all this respiratory distress, and almost we received in a right-sided congenital pneumonia picture. So this could have been managed better by starting on delivery only, as in treating as a early onset sepsis. What we follow, we could have started on admission only IV antibiotics at Padra CHC. So child might have not end up with all these complications. So the only thing key message is that there will be a lag of around almost more than 24 hours in starting the treatment of early onset sepsis from my side. That's my opinion. If anybody wants to
Yeah.
comment, then
Yeah, you are true. You are right. Early detection of sepsis is very important in preventing the mortality, right? So in this, maybe the treatment was delayed, but
delayed.
still
Yes.
you could achieve whatever the desired result, right? But
Yes.
early treatment is the key to prevent the mortality in sepsis.
In,
And even
in,
yeah.
in this case, where the baby was delivered, they have suspected vaginal infection, and even they have sent a swab also that came positive. So all these pictures suggest that we could have started early treatment within 24
Correct.
hours. So that
Correct.
could have a better outcome.
Right.
So that's my input only.
Yeah. Thank you.
Thank you.
So I think
So thank you so much,
Janki and Dr. Kunal for
thank you
having
so
me
much.
here. Yeah.
Thank you so much, ma'am, for asking such wonderful questions and guiding Janki through the case. Janki, a very well presented case. So within the short notice, what you have prepared was very commendable. It was excellently prepared. And Dr. Jayesh Solanki, thank you so much, sir, for mentoring and guiding Janki.
Thank you. Okay. Thank you. Thank you so much, Dr.
Thank
Thank
you,
you,
ma'am.
Anna ma'am. Thank you. Thank you, Shwetal ma'am, for being there.
Some network issue is there. Kunal, am I audible?
Yes, ma'am, you are audible.
Okay,
I
okay.
think
There is some.
due to monsoon, everyone has a network issue. We were also struggling with the
Yes,
network.
Yeah. Okay.
yes, yes. So it was really a nice session. Thank you so much.
Yeah. Thank you all.
Thank
Yeah.
you, ma'am.
Thank
Thank
you.
you, sir.
Thank you.
Okay.
We had to leave. So thank you all, one and all. Thank you, ClearNet, also, Ritu, for the seamless experience. Thank you so much, everyone.
Thank you.
We'll be meeting on next Wednesday again with a neonatal case between 3 to 4 p.m. So stay tuned for it. With due permission of Shwetal ma'am, can we end this session?
Yes, yes. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, sir.
Ritu, you can conclude this session. Ritu? Ritu Parna? I think she must be busy with something. We all can leave from our screens now.
Hello.
Yeah.
Yes, sir. Please tell me.
Yeah, we have finished this session. You can conclude.
Okay.
Yes.
Okay, sir. Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session. And we hope to have you again on our platform very soon. Thank you so much. Have a nice day, everyone.
Thank you. Same to you. Bye.